Hello, good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest from Germany, Professor Uwe Keller. Professor Keller is a professor and head of department in the Head and Neuroscience Spine Center in the Asklepios Clinicum Altona, and he is the president of the Hydrocephalus Society. As a specialist neurosurgeon, Professor Keller, together with his team, treats cerebral tumors, hydrocephalus, trigeminal neuralgia, brain injuries, cerebral hemorrhages, vascular malformations, and compression syndromes of the peripheral nerve. He has worked particularly intensively on the diagnosis and therapy of hydrocephalus over the last 30 years and is a recognized expert in the field worldwide. He is an invited faculty to several national and international conferences around the world, and he is an acclaimed author who has published numerous scientific papers on hydrocephalus. We are extremely honored to have him today at our webinars, and today we'll be talking about endoscopic third ventriculostomy, what you need to know. The speaker for the second session is our honored guest from China, Professor Yang Pengfei. He is an associate professor at the Department of Neurosurgery, Shanghai Hospital, Second Medical Military University, Shanghai, China. He is an expert in endovascular neurosurgery. He did his postdoc at the Department of Radiology, Wisconsin, USA. He has received several awards and honors for his outstanding contributions towards endovascular neurosurgery. We are extremely honored to have him today at our webinars, and today we'll be talking about endovascular treatment of ICAS related large vessel occlusions. The chair for the first session of today's webinar is our honored guest from Germany, Professor Klaus Resch, who is currently in Austria. He did his medical education from world-renowned neurosurgeons like Professor Yasher Gill, Professor Pornesky. He started his work with clinical anatomy and established a surgical simulation concept and training environment. He started with clinical anatomy, and he blossomed and refined endoscopic anatomy for neurosurgery under Professor Pernesky and progressed to endoscopic surgical simulation techniques for aneurysms, which became the basics for endoscopic assisted microneurosurgery. He is a renowned author for ultrasound guided neurosurgery. He has also developed the ICH evacuation concept and techniques for minimally invasive neurosurgery. We are extremely grateful to him for accepting an invitation to chair the session of Professor Keller. On behalf of the Education Committee of the ACNS and the President Professor Yoko Kata, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Klaus Resch.
Thank you very much having invited me to chair this session. And I want to invite Professor Uwe Keller to present his experience on ventriculocysternostomy at the floor of the third ventricle. Professor Keller is a well-known specialist in neuroendoscopy and in hydrocephalus, and he is the actual president of the International Society of Hydrocephalus, having done a very nice congress this year in Göteborg, and will be the president of the next congress on hydrocephalus in Hamburg, I guess. And he was chair in Altona, a very important place, Hamburg Altona, a community and city hospital, and a very important place because it was the starting place of in neurosurgery by Fedor Krause in 1880. In 1880, very early, some times ago, Fedor Krause started his career and became chairman in Altona also, and made wrote the Old Testament book of neurosurgery. Yes, in 2 volumes, and most techniques you will see today more or less evolved. He started with in that time. Yes, he started especially in pain surgery, cutting the 5th brain nerve, yes, cranial nerve. And so in this place, Professor Uwe Keller was working, so he had a very important chair there. So I now stop my talk, and I invite him very kindly to give his lecture. Thank you very much.
Thank you very much for this very nice introduction. I just have to correct a little bit. I am still working there. You know, I'm still working there, and I will work there over the next years. Well, it's a big honor for me to be here. It's a big honor to be invited by you, and I will give you some of my experience of endoscopic third ventriculostomy. And here you see this hospital we were talking about. This is the Altona Hospital, and it's a very nice view to the harbor of Hamburg, where all the ships are leaving, especially to Asia. Well, in the next moments, I just want to talk a little bit about endoscopic third ventriculostomy, as you can see it over here. This is only one treatment modality for hydrocephalus. Unfortunately, more often we have to do the shunt because the ETV, the endoscopic third ventriculostomy, doesn't work. But I will show you also the indications and so on in the next minutes. Why should we prefer an endoscopic third ventriculostomy to a shunt? It's because it's more physiologic CSF circulation. There's no overdrainage. We don't need implants. Of course, then we have less infections. It's cheaper and it's a very quick surgery. Well, we are very trained with endoscopic and shunt surgeries. We need for a ETV around 15 minutes, but for shunt, which is also quite quick, I think at least we need at least 30 minutes to do. But ETV is only good for obstructive hydrocephalus. I will talk a little bit about CSF circulation. Then I will go to indication for third ventriculostomy. I will say some words about endoscopic designs. Then I will talk about anatomy, anatomical variations, technique of third ventriculostomy, and of course, complications and follow-up. Well, how is it with CSF circulation? Everybody of you know how it is written in the textbooks. There is a choroid plexus. Choroid plexus produces so the textbooks, the CSF, and from the lateral ventricle is going through the foramen of Monro to the third ventricle, then through the aqueduct to the fourth ventricle, and then it leaves the ventricular system to the subarachnoid space. And somewhere in the subarachnoid space, it should be resorbed. This we just call the bike flow theory, coming from the choroid plexus through the lateral ventricles to the subarachnoid space, where it should be somewhere maybe in the arachnoid granulation resorbed. But how can we explain asymptomatic CSF pathway obstructions? And if we just look at the newer results, experimental results, we cannot see any net flow from the ventricles to the subarachnoid space. For instance, if you look at Clarica, at this publication, you will see this. So is that everything wrong, what we learned and what is written in the textbooks? At least we have to think about a lot of things. The modern understanding of CSF physiology just tells us and shows us that CSF is secreted and reabsorbed throughout the craniospinal axis, so in the ventricles, but also in the subarachnoid space and everywhere. Osmolarity is the key point there. It plays a critical role in CSF dynamics. Of course, there are the aquaporin 4 and the lymphatic system, which contribute to the CSF volume and flow, but also they establish the osmolarity gradients. CSF circulates throughout the subarachnoid space in the pulsatile to and fro fashion, and multiple studies demonstrate that choroid plexus does not play any significant role in CSF production circulation. So this makes it a little bit difficult how to explain everything with the bike flow theory and the indication for endoscopic third ventriculostomy. And just look at this case over here. You have a tumor in the cerebellum, and this is occluding totally the CSF pathways. The fourth ventricle is occluded. The outflow of the fourth ventricle is here occluded. And as you can see it here, but no hydrocephalus and no symptoms of a hydrocephalus at all. And you also will see other patients with aqueductal stenosis or aqueductal obstruction who will not have symptoms and no hydrocephalus, whereas others will have a severe hydrocephalus. Well, as I said, osmolarity plays a very important role. And if there are changes in osmolarity, then CSF still has to flow from the ventricles to the CSF pathways. So you need an obstruction of the CSF pathways and a change of the osmolarity. And this may rescue the bike flow theory. And you can see it here. And this bike flow theory just works very well in those cases like the aqueductal obstruction with this tumor of the quadrigeminal plate. You see that the pre-stenotic spaces are enlarged and the post-stenotic spaces of a normal size. As you can see it here, the obstruction of the outflow of the fourth ventricle, or here it's a special case, it's the infratentorial intracisternar obstructive hydrocephalus, where it's a communicating hydrocephalus as it look like, open aqueduct, open foramen margin D, great. The great cistern is enlarged, but the prepontine cistern is of normal size. So in between here must be somehow an obstruction. Well, with that, what I just said, if we have some obstruction somewhere, we will have a higher pressure pre-stenotically, and what will show us, and we will have, for instance, downward bulge flow of the third ventricle, a very important sign for the indication of third ventriculostomy. And then we just can go in, we may do a hole over here, and we will bypass those obstructions. The hole you can see over here. Well, for the indication of third ventriculostomy, we need, of course, a morphological correlate. I will show it to you again immediately. Of course, we don't need only the pictures or the imaging. We also need clinical symptoms for indication of a surgery. And what is that? That is an acute obstructive hydrocephalus. We will have elevated ICP with headache, with drowsiness, maybe even with unconsciousness. If we have a chronic obstructive hydrocephalus, like also chronic aqueductal obstruction, patients will have symptoms like a normal pressure hydrocephalus with gait disturbance, incontinence, and cognitive decline. And for the indication of third ventriculostomy, we also have to have a neuroendoscopic know-how. So never start neuroendoscopy if you're not familiar with the endoscope, or if you do this, you need somebody at your side with this know-how. Otherwise, it would be risky. Well, what about with this obstructive hydrocephalus? We have an obstruction of the foramen of Monro. We have large ventricles, and we have a normal size of the third ventricle. So if we have here in the level of the foramen of Monro, if we have an obstruction over here, we will have an enlargement of the pre-stenotic spaces. That means the lateral ventricle, as you can see here, and the post-stenotic spaces of normal size, as you can see it here. Or here you have a membrane on both sides of the foramen of Monro. If we would do a third ventriculostomy, so a bypass from the third ventricle to the subarachnoid space, we would do communication between some spaces which are communicating already. So this is not worthwhile to do a third ventriculostomy. Of course, we could go here with the endoscope inside and resect the colloid cyst, and here to perforate the membranes of the foramen of Monro. Let's look at the aqueductal stenosis over here. You see all the pre-stenotic spaces are enlarged. the floor of the third ventricle should be in this level, but it's downward bulge, and also the lamina terminalis is pushed forward. And when we do now a third ventriculostomy at this place here, the floor of the third ventricle to the prepontine cistern, you see we get a connection from the third ventricle to the subaurial space. This would bypass, of course, this aqueductal stenosis, and we could treat with endoscopic third ventriculostomy this aqueductal stenosis. The same here with the cyst of the posterior part of the third ventricle, which occludes the aqueduct and makes an obstructive hydrocephalus as well. We can go and do a third ventriculostomy, or we go here and we just resect with the endoscope the cyst, or open the cyst at least. Well, here with the obstruction of the outflow of the third ventricle, you can, if you do a third ventriculostomy, as you can see it here, you also will bypass this obstruction, and it works very nicely. I will show you later also. The same here with the anal-Chiari malformation, where the cerebellum is just entering the spinal canal and is obstructing the outflow of the third ventricle. It works very well with the third ventriculostomy. And this is also a case, what I showed you already, this infratentorial intracisternar obstructive hydrocephalus. Here you see a communication to the fourth ventricle, to the great cistern, but you see a discrepancy of the size of the great cistern and the prepontine cistern. Although you cannot directly see the obstruction, with indirect signs you will see this obstruction. I come back to this a little bit later. If you do a third ventriculostomy here, you can also bypass this obstruction, which should be somewhere in between here. If you look at the imaging, it's essential that you look especially at the floor of the third ventriculostomy. And here, this dotted line show you where is the normal position of the floor of the third ventricle. And you will see also the lamina terminalis, also an important sign. And in all those cases, with an obstructive hydrocephalus in the two upper rows, you will have an obstructive hydrocephalus. Lamina terminalis is all pushed forwards, and the floor of the third ventricle is pushed downwards. If you have a communicating hydrocephalus, these are two examples of a normal pressure hydrocephalus. The floor of the third ventricle is a normal position, and the lamina terminalis is also in a normal position, concave to the anterior part. The same here. Here also the floor is pushed upwards through an elongation of the basilar artery. Well, before we do an endoscopic procedures, we should look a little bit at the designs. We have, especially if we have rigid lens scopes, we have to look at these special designs. You may have only one channel for the optic and all the instruments, or you will have separated channels for all the instruments and for the optics. If you go, for instance, with this endoscope in the lateral ventricle and you go down to the third ventricle, if you put the endoscope on the tip, you won't see the rim of the sheet, and you may harm the fornix or the structures of the foramen of Monro. In here, because this is all blunt, if there are some membranes inside, the problem is less to do some complications here, but still there are some possible complications I will tell you a little bit later. You should all the time, if you use it, all the time use a 0 degrees optic. Only if you're in with a 0 degrees optic and you have orientated your well, you may also use, of course, other optics, but at the beginning, it should be 0 degrees. Well, here you will see, if you go with the endoscope inside the ventricle, some anatomical normal anatomy and some variations. You see very nicely here, you are inside the lateral ventricle, in the right lateral ventricle. You will see the fornix, you will see the thalamosteroid vein, you will see the vein of the septum pellucidum, and you will see the fornix over here. The same here. You can see the thalamosteroid vein, the fornix, and you can see even through the large foramen of Monro inside the third ventricle, and you can see the mammillary bodies. Here, it's a long-standing hydrocephalus, and there's no septum pellucidum anymore. So this looks very nice. You see the foramen of Monro on the right side, on the left side. You see the fornices, both sides. This is the roof of the third ventricle, and below this there are the internal cerebral veins and the choreoplexus of the third ventricle. You see it here, it's also quite clear, but if you had the bleeding or infection in earlier time, it maybe look very differently. Here it's already different to say exactly what is what, but you have still the choreoplexus, and the choreoplexus usually helps you, but you will have a lot of membranes. If you had an infection, it can be very difficult. And also here, so where we are here, well, we see a little hole. This hole was only 1 to 2 millimeters large, and it was very difficult to understand where we're here. You see this yellowish things over here. This are the remnants from intracerebral or intraventricular bleeding. This here was the thalamosteroid vein, and we just went in here and we opened it. This was just a small, tiny membrane, but we could see it from the beginning. This was the foramen of Monro. And then we go to the third ventricle. You see the third ventricle, and you're very happy if you have a translucent third floor of the third ventricle, because you may see everything. You can see here in the front the chiasma. You see the infundibulary recess. You can see here the clivus. And you will see here the basilar artery with the both posterior cerebral arteries and all the perforating arteries to the brainstem. This is very important to know this, because here, if you do a third ventriculostomy, you have to be all the time anterior to the basilar artery, never go in here. What you also can see here is the posterior communicating artery, and somewhere here must be also the oculomotor nerve. Well, just look at this here. Here we had a very large downward bulging flow of the third ventricle, the mammillary bodies. You see here the vessels from the basilar artery just almost at the clivus. And if you see here, you would be challenged to go here to do your third ventriculostomy, but never do it. You will just lesion some tiny vessels, some tiny perforating vessels. You get a bleeding, and I will show you later what is going to happen. Well, here it's still clear. Here you see that you cannot see anymore very good the underlying structures of the floor of the third ventricle, as you don't know anything exactly. Where is the basilar artery over here? Is it here? Is it very much here already, attends to the clivus? You don't know, and here you cannot see anything. And here it's very difficult to say what is what. If I saw this the first time, I said, oh, this is probably the chiasma, probably we have to do our third ventriculostomy here. Here I wasn't really sure. I'll show you later a little bit. So you have to have all the structures what you can lesion in mind. I don't want to go into detail, but here where is this little star here, you should do your third ventriculostomy. Quite easy if you see where you go. Difficult and dangerous if you don't know exactly where you are, because the floor of this third ventricle might be not translucent as it is here. And here, where to perforate it? So we perforate it here or here. So you should have all the time the MRI in your mind, and you have to you should look very carefully at the MRI, and then you will see it. And here is your MRI. You can see this is a chiasma. Well, this is anterior, this is posterior here, and this is, as you can see it, this is a chiasma. If we would go in here to perforate it on here, we would go anterior to the pituitary stalk. And where we want to go is to the prepontine cistern. So we should have to go here. But then it's still difficult. Where is the basilar artery over here? So you should look all the time at the MRI, and so proper preparation is indispensable for all surgeries. Even it's an easy surgery. If you have done it very often, you still should prepare every surgery individually. So now you did see all the anatomy and the anatomical variations. Of course, if you do a third ventriculostomy, where to do the borehole? While we know we want to do the perforation here, just anterior to the basilar artery and posterior to the clivus. So this defines, together with the foramen of Monro, the tract which we will need with a rigid endoscope. Of course, it's a little bit different if you could use mobile or flexible scope, but the vision usually is not as good. So these 2 points determine now where you have to do your borehole. If you have a rigid endoscope, you do your borehole here, you will directly come here if you go through the foramen of Monro. If you don't look, if you do it over here, you will have really problems. Well, now we know where it is, and if you do not have navigation, you just can calculate it on the MRI or even on the CT, how much is the distance from the inion, and you can measure it at the patient, you will find it exactly. How much lateral it should be, the borehole. It should be as midline as possible, but of course there is a sagittal sinus, so you have to go around 2 centimeters to the lateral. But if you go too far lateral with your rigid endoscope, you will come in the third ventricle to the opposite side, and you may harm the oculomotor nerve, you may harm also the posterior communicating artery. So keep in mind, the perforation site and size of the foramen of Monro determine the position of the borehole. Here you can see it, how we do it for the patient. If we don't have a navigation available, or we don't just do it like this, we just measure the distance from the inion. What we have measured over here, we mark the situation, and we go about 2.5 centimeters to the lateral position. This is the midline. And usually the borehole is at the coronal suture, but sometimes it's quite 1 or 2 centimeters behind, or 1 or more than 1 centimeters just anterior of the coronal suture. So just say only it must be on the coronal suture. You will have no problems if you have a large foramen of Monro, but you will have problems if you have a tiny, small foramen of Monro. Well, if you go to the, if you go inside with your endoscope in the lateral ventricle, if you don't see any plexus, chorial plexus, you have to go posterior, because in the anterior part of the third ventricle there is no chorial plexus. So you have to go in this situation a little bit backwards. If you see only chorial plexus, but you don't see the foramen of Monro, you have to move anterior. I will show you. This is a movement you have to go to arrive at the foramen of Monro. Now we just do together third ventriculostomy. We are in the ventricles, the vein of the septum pellucidum, fornix, chorial plexus. We go through in here. You see the chiasma, the infundibular recess, the mammillary bodies, and you see here already the floor. You see here we have a little sharp instrument because it wasn't easy to perforate it, and you will see that we just rotate the sharp instrument away from the vessels. I rotated a little bit toward the clivers, and I did a little hole here. I was afraid just from the beginning with a large Fogarty catheter to do it. And if I have a little hole, then with a larger catheter, it's very easy to perforate it. And if I'm in here, I have to go a little bit deeper with the Fogarty catheter. Just wait a second here, and now I blow up the balloon, and it will open the floor of the third ventricle, as you can see it over here. So sometimes this is quite easy, sometimes a little bit more difficult if the floor is very, very tough. And when I have done it, sometimes I have little bleedings. I just can stop bleedings with blowing up the balloon. You see here what I'm going to take it out, and now you can see this vessel here. You see the basilar arteries. There's no additional membrane. I have done my job. And if I have done my job, I should not go through the whole ventricular system, even it's so nice to go through it. No harbor cruise. You should go out and do your job, finish your job. There were some cases in the literature, people were just so fascinated from the anatomy, they were harbor cruising through the ventricular system and got some bleeding. So don't do it, just do your job. As Alan Cohen said in former times, do it like a bank robbery. Go in there, do your job, and run away. Well, here you see another very nice case, and here it's also so fantastic to go all over through it. You see there's almost no septum pellucidum. You see the fornix over here, the fornix on the other side, and you see here these vessels from the septum pellucidum. If you lesion those, you will get a bleeding and you will not see anything anymore. And so it's very nice, but please don't do a harbor cruise in the ventricular system. And here we were also lucky. The floor of the third ventricle was translucent. You can see the basilar artery. You can see the posterior cerebral artery, the communicating posterior artery. You can see the pituitary gland as well. And here I show you how we did the perforation. Here was a bipolar probe, a very short coagulation, and if you do a coagulation, then often you can rupture very nicely the floor of the third ventricle, but of course you still have to open and further on. I go in here with a Fogarty catheter as well, as you can see it, as I go a little bit further on. And now it's ruptured, and you can see the basilar artery, and you can see that there's no further membrane. But don't try to go in this area over here. You remember there are a lot of perforating small vessels, but they may bleed if you go here. You can harm them very easily. Never go here, just go in this area. And now I'm just going in with the endoscope. And I see here that there's no further membrane. You can see the basilar artery over here, but don't do more. What you can see very often that the floor of the third ventricle is just moving with the circulation of the CSF, which is a good sign. Okay, I show you some different perforation techniques. This is a blunt perforation technique, what I showed you already, very easy done. And of course, you like it to do it so easy if it's so close to the basilar artery. I showed you the other technique with the coagulation, which is also very nice to do. And then afterwards blowing up this with a balloon. But you see this now we had some problems. Well, it's translucent and you think probably it's easy to perforate, but what you see here, I tried to perforate it. I cannot really perforate it. You see, and you should not really use force to perforate it. You have to perforate it sharply. And we have the sharp probe here, which is a little bit angulated, and this angulation we do just to the anterior part away from the basilar artery. And if we have a small perforation already, as you can see here, if you have a small perforation, you can enter in there with a Fogarty catheter with less force. Of course, you could use a smaller Fogarty catheter at the beginning, but we tried it first with this one, and you see just with a little bit force you can open this this little hole, what we did with the sharp device earlier. Well, how large should the stoma be? There's all the time, over the last 30 years, discussions about it. Of course, it should be as large as possible, but you should this enlarge without any risk. If you have really problems, don't try it with force to have a very large one. Usually, my ETVs are have a size of 3 to 4 millimeters, and this seems to be quite enough. Of course, as large as possible, but please without any risk. And you see also what I said before, that the floor of the third ventricle is moving so much with the circulation, which is a very good sign. This case, for instance, was very tough. It was much more difficult to open this here. And then, if you have done your job, you should remove, of course, your endoscope. You just go a little bit out there. You will look at the foramen of Monet. Everything is fine. No problem here. No lesion over there. And if you go then through the puncture of the brain, you should also look if there is some bleeding over here. And you see there was no bleeding, so you just stop your surgery. How to close the borehole? You should close the borehole all the time, that it is also cosmetically nice and it is watertight. So what we do, we just do it with bone wax, as you can see here. If you don't use bone wax, you will have it like this in the patient, and it's cosmetical, a catastrophe. And you see, I have a bald as well. I don't like to have it. Of course, it doesn't mind so much if you have a lot of hairs, but if you have a bald, it's really terrible. And people will ask you, oh, what have you done there? And you should not have this. Well, you see here how it looks like in our OR. I just must admit, this nurse is an additional nurse who was teaching the nurse who was doing it the first time. But this is my assistant. My assistant is just my endoscope holder, and I'm doing the procedure, and we just can very comfortable look at the screen to do it. You see it here. We usually do a curved incision, just in case that we later on have to do a shunt. For what reason soever, we like to have the shunt under the skin and not under the scar. And this is plus, and we usually, if everything works well, it takes about 15 minutes from incision to the suture. But there might be, of course, some problems, and you should be aware of this. Sometimes the ventricular puncture is problematic, maybe because of small ventricles, or maybe you have rigid ventricle walls. If you have those problems, especially in small or slit ventricles, you should use, of course, neuronavigation. And you just can put very nicely the navigation to the endoscope, and then you can use it like this. It's very nice, very safe. What you also can use, you could use ultrasound, what we also do several times. And what we are starting now with is with augmented reality, that I have a glasses on, and I will see the ventricular system in the depths, and I will see as well the skin. Well, sometimes the walls of the ventricles are very rigid. And what will happen then, or may happen if you just puncture the ventricle with the endoscope itself, you may push the wall of the ventricular wall in front of the endoscope, like you see it here, and it will not open. And you will also go to the other side of the ventricular system, and you may harm over here. What we do in those cases, or what we do, therefore, all the time, first we do a puncture, usually with the Cushing cannula, which is small and where the ventricle is ruptured very easily. If you have already a little hole, we go with the endoscope through the canal in here and go in here without having this problem, what you can see here. We may have fornix lesion. I showed you at the beginning one reason of fornix lesion, but if you have those endoscope with several channels, you must be aware that you have a dead angle from where your instruments exit the endoscope until they come in the visual field. And if you're with the endoscope just in front of the foramen of Monroe, you think you are already totally inside the third ventricle, but you're not. And so if you come out in the dead angle of the endoscope, you may lesion the fornix, for instance, as it may happen here. Or, of course, if you have a wrong entry point with your endoscope, then you just go in here and then somehow you try to do to pull and push the structures of the foramen of Monroe just to get in here. That's not good. If you have this problem, better to go out, better to say, oh yes, I made a mistake, I have to go in here and do it then in the correct and less harmful way. Of course, you may have vascular lesions. I showed you around here with this tiny vessels of the septum pellucidum, which is not anymore there because it was such an extended hydrocephalus. But if you go to the other side to look, because it's so fantastic view, if you do your harbor cruises over here, you may lesion those vessels and get a real problem. If it's bleeding, you will see only red. It's the same if you go here. This was the case I showed you. If you go in here for the perforation, and you will lesion the perforators, what you will have something like this. If you get a bleeding, you just have to rinse and to rinse and to rinse. If you have a venous bleeding, usually it will stop. And after half an hour or something like this, maybe even earlier, you will see something again. But if you have an arterial bleeding, it will never stop. You should take out the endoscope, put an external ventricular drainage in, and stop the surgery. Well, it's very nice if you have a translusion floor of the third ventricle, but be aware if you cannot see through the third ventricle. These are for some more experienced neurosurgeons to do that. Here, of course, this is where also the beginner can start, but still, if you are a beginner, you may have a problem with the vessels here because there's not a lot of space. So just be prepared. Here you still have some problems because this vessel is so close to the clivus. And in those cases, I showed you also this case how we did it, that we go with a sharp angulated catheter on the clivus. This is away from the basilar artery or from this artery, that we do not harm the artery, and you push it on the clivus down and you get your hole over here. If you go in here, you will get this read out, what you don't want to have. But with this perforation technique, you have also one problem. If you just go on the clivus, you may come in the subdural space. The arundite is often lying on the dura. And well, if you perforate it here, you also usually perforate this arid as well. But if you go here in front, you may also go in here on the clivors, and then you will have a hole, but still no communication to the subarachnoid space. So that is the reason why you all the time have to go through with the endoscope through the third ventriculostomy, and to see that you have a clear vision to the basilar arteries, that you're sure that you're inside the subarachnoid space. Well, if you do a third ventriculostomy, you need, of course, to follow up. You don't need, if patients are very well after surgery, you don't need necessarily an MRI, but it's of course nice to demonstrate how it is. Here we had the obstruction of the fourth ventricle. We did the ETV over here. You see now post-operatively a flow void over here. The floor of the third ventricle, what was downward bulge, is in the normal position. And what you can see, the size of the ventricles, and especially here of the fourth ventricle, is going was decreasing, even if it's not going back to normal. Or here with the aqueductal stenosis, what you had over here, you could see the floor of the third ventricle is up in the normal place. You see a little flow void over here, and also the lamina terminalis is in the normal position. Here again, I want to show you the infratentorial intracisternal obstructive hydrocephalus, or infino. You see the floor of the third ventricle was downward bulged, and the lamina terminalis was pushed forward. After surgery, there's almost a normalization. You can see the hole over here, and the lamina terminalis is in the normal size again. Please be aware, sometimes you have good imaging result, as you can see it over here, but clinical, we weren't really satisfied. This was a slight improvement of the situation, but not as much as we hoped it will be. In those cases, you should do a spinal tap test and see if there is more improvement, and then you need to put a shunt in. So be aware, if the clinical improvement is not as good as you expected, then you have to do further investigation, and you may do a shunt in those cases. So keep in mind, improve imaging features do not necessarily mean clinical improvement. And therefore, an ETV is so, the follow-up is so important. You know, there are a lot of papers in the literature that you have improvements after ETV, and they said it's a success of ETV. However, you can see it over here. You have a deterioration until surgery. Then you do the ETV, and you have only a slight improvement. Well, it is an improvement, but it's not enough, especially if you do a spinal tap test. You see you have a temporary better improvement. In those cases, you have to you put a shunt in, and you see what is going here to have, you will have a really long-term success rate. So be aware, if you're not satisfied with the outcome with the ETV, do a spinal tap. Well, of course, you do an imaging, you see if the ETV is open, and if it is open, you do a spinal tap test, and if there's a temporary improvement, shunt, please. Well, I was talking a long time. Now I'm going to the coming to my summary. Well, the indication is the obstruction between the distal part of the third ventricle and the prepontine cistern. There you have a rationale why it could be obstructive. You will bypass the obstruction. If you do a ETV, proper preparation is indispensable. You need to do it, otherwise you will have or confronted with surprises and complications. Be aware of all the anatomical fractures and no harbor cruising with the endoscope. Even I can understand everybody is such a fascinating anatomy, but still don't do harbor cruising. Follow-up is necessary and essential for the patient. And if improvement is not as good as expected, do an MRI. If this is open, do a spinal tap test and possibly a shunt if there's temporary improvement. Well, with this, I will stop my presentation. I just want to say you that we do also a webinar from the Hydrocephalus Society, and you will find a lot of topics about everything about hydrocephalus, and you can look at this internet site and just register now. And I want to invite everybody of you to the Hydrocephalus 2023 meeting, which will be in Hamburg. You see the new concert hall, the Elbphilharmonie. Also, the Congress will not be in the Elbphilharmonie, but you will have a nice city and you will have, I promise you, a nice meeting over there. Please register to this as well. With this, thank you very much. And I happy to questions of you. Thank you very much.
Professor Kehler, thank you very much for this excellent lecture about the standard problems and the standard techniques which everybody who go into this field should know and should train. And this gives me the chance also to comment that the major problem actually we have in Middle Europe regarding endoscopy in neurosurgery in general is the education situation. And therefore, I'm very happy about your efforts that you are training the youngest since a long time. And this is very important for everybody who wants to go in this field, have a good training, go to the different training locations. But the best way, of course, would be if you build up a training occasion in your own hospital. Because to go to a one day or some day training will not be enough. It is better to have a training opportunity in your own department. Second, beside the fact that the education is the weak point in neuroendoscopy, still, for me it's much easier to get a ETV done in Mexico than in Middle Europe, because diagnostics, all the discussions, not well-trained assistants is a big problem, and therefore sometimes it is easier to put a shunt, which is a bad indication way to put a shunt because the education of ETV has not been done well. So we of course have heard now all the very, very important standards in an excellent way by Dr. Kehler. And of course, you should know that there are much more possibilities. There are very single difficult cases that can be done by endoscopy also, but not by the beginners. Therefore, it is important just to have heard the main important features and techniques, and they should be trained. On the other hand, for the future, maybe we will have an advanced course where we can present the difficult cases and what we can do. My first question to Dr. Kehler is, did you ever do the ventriculocysternostomy through the corpus callosum?
No, I never did, but I showed you one case where you did not have any septum pellucidum, where also the fornices were almost far away from each other. So there might be some exceptional cases where you could do it, but this shouldn't be the standard, and this shouldn't be, of course, not for any beginner.
Can you give us a very short comment on the rule of ultrasound in neuroendoscopy? Because you have mentioned that you sometimes use the ultrasound.
Yes, the ultrasound for third ventriculostomy, there is only very, very tiny role. There's of course a role if you have problems to get into the ventricular system, so you can just steer the endoscope under ultrasound. We have a very tiny ultrasound head with what we can put in the borehole or slightly enlarged borehole, and you can see how the endoscope is going into the ventricle. It might be, but there, of course, it's a problem with a lot of probes. If you cannot see through the floor of the third ventricle, that you might put the ultrasound probes there just to see where it is. But most of the ultrasound probes are too large to get in there. But if you have a special probe, or you have a special company who delivers such a probe, you can do this, and this is then a good indication. But of course, we have other endoscopic procedures in the ventricular system. If we have cysts, if we have membranes where we have in a complicated hydrocephalus, loculated hydrocephalus, so also can be very helpful to have the ultrasound as well.
Another question is, because some of our colleagues have done this, what do you think about the laser, the transendoscopic laser? Is it needed? When would you indicate it?
Yeah.
Is there an indication?
Well, there are different perforation techniques you can use also with a laser. The laser is not available for many people, and you have to be aware which kind of laser you have. If you have a laser who is doing the hole only just at the surface and not going to the depths, that's no problem, but you may have lasers with the effect to the depths, and this is very dangerous if you go to the third ventriculostomy. So we are very happy with our perforation technique, what I showed you. We don't need this expensive additional equipment, but you may have, especially if you have colloid cysts, sometimes if you have submarine cysts, which are very difficult to perforate, the laser can be of advantage. But for third ventriculostomy, because you have so many vessels just below the membrane, it's dangerous.
So a last question by my side. How do you deal the cases with very high basilar tip, which you can see even in the foramen of Monroe already?
Yes, if you have a very also the basilar tip, or can be the cause for obstruction on the cause of the obstructive hydrocephalus. Well, if you look very nicely at the MRIs, you can see if you can do it, maybe coming from the other side. It's very rare that you have those cases, and you have to look. But if you have any doubts in those cases, if you are afraid that you may harm the patient, or you're not even clear if this is a poorly obstructive hydrocephalus, you may put in those cases a shunt. What is important, not to risk something. Well, of course, everybody of us like to do the third ventriculostomy and the endoscopic procedures, but don't overdo it. If you have some risk, if you see there is a problem, just say, I don't want to harm the patient. Better to say, oh, probably I did a mistake, but I continue less harmful for my patient.
Perhaps one last question, a technical question. Do you have the prepared microscope beside you during endoscopic procedures?
No. I'm doing the endoscopic third ventriculostomy now more than 3 decades. Well, we had some problems, but we never had a severe bleeding. We never needed to have a microscope. It's different if you do some tumors in the ventricular system, or if you have also for colloid cysts or something like this. That's different. But for the third ventriculostomy, no, we don't need it.
Okay, thank you. Thank you very much for this excellent presentation.
Thank you very much.
Well, thank you very much. It was indeed a very lively session and a lot of information shared. Thank you very much to both the chair, Professor Klaus Resch, and the speaker, Professor Uwe Keller. Professor Keller, two questions I would like to ask you. The first one is like in an alternative to the ETV, where you showed few cases, and as well as our chair pointed out, in a high riding basilar artery, as well as and there is no gap between actually the mammillary bodies and the infundibular blush. What are your opinion regarding endoscopic transforaminal fenestration of the lamina terminalis, which may be an alternative option? What is your views about that?
I'm a little bit doubtful because first of all, like if you have a device which is angled towards the clivus, as I showed you, you don't have the problems even if it's a narrow space between the basilar artery and the clivus. The good thing is if you go to the clivus, you will have a counter force for your device to perforate the floor. If you go to the lamina terminalis, what you could go, you may have also a lot of vessels over there, and you don't have this counter forces. So you may just, especially if the lamina terminalis will be a little bit more tight, you will push it forward, and you may not perforate it. It's for me, it would be an additional risk, and therefore I don't want to do it. I know you can do it. We do it quite often if we do a aneurysmal surgery, just coming from the other side. But I'm afraid to do it with the endoscope, so we don't do it. But in some cases, it may be easy, but it may be also more risky.
Thank you very much. Another question is regarding the follow-up. As you showed, if there is no adequate response, you may do a spinal tap, and after which, if there is a response, you can put in a shunt. This is mostly regarding normal pressure hydrocephalus that we do, and your expertise is largely focused upon adult hydrocephalus. In pediatric patients, where it is very difficult to evaluate clinically, are there any scores at all where you propose that you can use for evaluation?
I would like, if it's possible, I would like to have an MRI. And this MRI, if you have the possibility to get the MRI, you can show if the stoma, what you did is open, and you have a flow void. So in those cases, I don't want to recommend to go back in there to look around there. If you don't have the flow void, and if you don't see if you don't see the obstruction, the reobstruction, or if you see in the reobstruction of the floor of the third ventricle, of course, then you should go with the endoscope in again. It's differently in children and young adults than in elder adults. You're right. We do have reclosures quite rarely in adult people, but in younger people, it's much more often. So in children, you may go easier again in to look if it's open and reopen reoccluded stoma.
Thank you very much. Yes, our colleague from Hong Kong, Dr. Ben, has raised his hand. Ben.
Hello, Professor. I'm Ben, a young neurosurgeon from Hong Kong, and thank you so much for your very educational lecture. I have a question. It's about sometimes we need to do the biopsy, for example, some pineal tumor or other ventricular tumor. Would you prefer to do the biopsy first or ETV first? And what's the rationale behind? And would you also prefer using a 2 burr hole instead of a 1 burr hole if you need to do the biopsy? So thank you, Professor. What's your opinion on that?
Yes, well, if we have an intraventricular tumor, and what we do first in those times, all the time, the ETV. Why? Because you may have a bleeding from the biopsy, and then you cannot see it anymore, and you cannot do safe anymore the ETV. So first, you will treat the hydrocephalus. This is the what is usually also what is endanger the patient, and then after you have treated the hydrocephalus, you will go and take the biopsy. If you get a bleeding, then it's not so difficult. Of course, you take out the endoscope in the end, or rinse, and if you cannot see, you can take out the endoscope. But you have done already your third ventriculostomy. If you do it the other way around, you won't be able to do safely anymore the third ventriculostomy. So that's the reason, the rationale for that. Usually we, you have different designs of endoscope. If we want to have a large biopsy, of course, it's easier to have this, if you have this available, to have the endoscope sheet which has only one channel. This is easier to perform, and you can get bigger specimens. Why is this?
Thank you so much.
Yes, my co-host Liu Bun Seng, any comments from you?
Thanks, Raja. Thanks, Professor, for very nice talk. Professor, I want to find out from you that for an ETV, do we necessary to have MRI, especially in a patient that impending corning? So whether can we do just with CT scan? My second question, Professor, regarding the prepontine space, if we have MRI show very narrow prepontine space, is there any instances where ETV cannot be done just looking at the MRI? My last question, Professor, for those who do not respond well with ETV, and you suggest spinal tap, do we need to do an MRI to rule out closure of the fistula before we attempted spinal tap? Thank you, Prof.
Yes, the first question was, just let me know, this was...
MRI
before... Yeah, the MRI, well, with the MRI, well, if you would ask me this question 10 years ago, I would say yes, you need an MRI. But nowadays, the CT scans, especially with the sagittal reconstruction, are so good that you can do it with the CT scan as well. Of course, I enjoy much more the MRI because also you will see all the structures. You can see also the basilar artery. You can see a lot of structures. So if you prepare yourself, it's more safe with an MRI. But yes, you can see the obstruction, and you can see also the downward bulge floor of the third ventricle with a good CT scan today. Well, if there is such a narrow space between the brainstem and the clivus, it's even a touching there. I never had to stop a surgery because of this, but of course I'm very happy if I can do a blunt perforation without force, or if I have some problems. I showed you the technique with this sharp anterior angle device, so there's also no problem, no risk of having a lesion of the artery of the brainstem. But there you may have the risk that you just go to the subdural space and not to the subaurial space. This may happen, but you will see and you will recognize this. You will recognize this when you go with the endoscope in and look at the prepontine cistern. I would, if you have done an ETV and you are not satisfied with the whole or with the clinical improvement afterwards, we do all the time first an MRI just to look if everything is open, if the opening of the floor of the third ventricle is still open, if there's a flow void. if this is open, yes, then we go for the spinal taptis. If we see that is re-occluded, and we still have an obstructive hydrocephalus, no, we wouldn't do a spinal taptis. We would go in and do a re-ventriculostomy.
Thank you very much, Professor.
Well, thank you very much. There is one question that is remaining in the chat box. Any experience regarding the use of flexible scope for ETV? And what is the rate of failure for ETV?
Well, I do have experience with flexible scopes only in cadavers. And I was joining or attending a lot of surgeries where they use flexible scopes. Flexible scopes are more expensive, difficult to re-sterilize, and they have also worse vision than lens scopes have. So that's the reasons why we don't use it. But of course, in several circumstances, it can be very helpful to have a flexible scope. Also, if, for instance, if you will go with a flexible endoscope through the aqueduct to the fourth ventricle, you can't do this with the rigid endoscopes, and you need a flexible scope to do this, not to harm it. But you also have to be aware, also with a flexible endoscope, if you're not aware of, not with the training, you may have also some problems because you will have a long dead angle where you don't see exactly what you're doing. But a flexible scope can be an adjunct to a rigid endoscope, very helpful. For third ventriculostomy, usually you don't need it. But for instance, if you haven't done your borehole at the right position, you can just go around the corners there, and you may be then helpful. But better is a better preparation before surgery that you don't get in this problem.
Thank you. Thank you very much. We had a wonderful session, and I would like to inform our viewers that this is being broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 400 people who have already logged in to see us live. We're extremely grateful to Professor Shubin for broadcasting this on the WeChat channel. And I would like to sincerely thank once again Professor Klaus Gress as well as Professor Uwe Kehler for this wonderful session about ETV. So we'll move on to the second session. So I'll invite Professor Pengfei for his talk about ICAS related LVO. Professor Pengfei, all yours.
So good night and good morning, good afternoon, everybody. It's really my honor to be here to join this ACNS webinar. I'm Pengfei Yang from Shanghai Hospital. I've been trained to be an endovascular neurosurgeon. So my specialty is endovascular neurosurgery. When Dr. Xu invited me to give this talk, I just think about over and over. I think it's better for me to try to find a unique disease in Asian population. So finally, I just try to discuss about this topic, how to manage ICAD related large vessel occlusion. As we all know, acute large vessel occlusion has become one of the most severe disease in the neurosurgery field, and especially after 2015, mechanical thrombectomy has become the first-line therapy for the acute large vessel occlusion. However, in Asian population, the acute large vessel occlusion, there are a lot of patients are due to ICAD related large vessel occlusion. So in China, according to our data, we just saw there are about 40% of the patients, their large vessel occlusion are due to intracranial atherosclerotic stenosis, and the other 60% may be due to the embolic stroke. So I think there are some key questions about ICAD-related large vessel occlusion existing now in our field. The first is how to identify an ICAS-related large vessel occlusion, which is there an ICAS? And the second question is about how to manage an ICAD-related large vessel occlusion. This may be divided into three questions. The first one is, should we do the mechanical thrombectomy, I mean using stent retriever first for ICAD related large vessel occlusion. And the second is, should we use ADAPT, I mean the aspiration as a first line therapy? And the last is about based on those thinking, how I do it for ICAD related occlusion. So the first important question is there an ICAS for acute large vessel occlusion? So usually we have a lot of steps to try to identify for the patients if there is ICAS related large vessel occlusion. So before the procedure, we can judge the etiology of the large vessel occlusion from the original CTA, and we can find the occlusion location of the vessel, and also we can identify the shape of the residual artery. And then if for these patients, if we have some prior vascular images, and if there is a stenosis, and this time we find acute occlusion, we can be 100% sure this is ICAD related occlusion. And then the last is about the symptoms of the patients. If this patient has a history of a TIA and also some other comorbidities related to atherosclerosis, just like a long history of hypertension, diabetes, and a heavy smoker, and something like this. So for those reasons, these patients was more likely to have ICAD-related occlusion. And during the procedure, we can always feel it's difficult. It's relatively difficult for the wire and the microcatheter to pass through the occlusion site. But you know, this is a kind of personal feeling, and sometimes I think it's relatively difficult, more difficult than embolic stroke. And the second is, if we just do a stent retriever, we put the stent retriever there, we can see the distal blood vessels, and we can see the complete reperfusion after stent deployment, which means if it is embolic stroke, it's usually the embolus is located in the bifurcation site. So if we just place a stent retriever, we can only see the vessel, the distal branch, where we put the stent. But for the other branch, the other bifurcational branch, it is still occluded. But it is, if it is ICAD-related occlusion, usually the ICAD lesion is located in the trunk. So if we put a stent retriever, all the distal branches should be visualized. And the fourth is about when we try to retrieve the stent, when we pass through the occluded lesion where there is ICAS, usually we can see the distal end of the stent retriever will be just get close. And the fifth is about the clot burden. Usually for the ICAD-related lesion, the clot burden is relatively small, but however, it is depend on the time of the occlusion. And after the procedure, after the mechanical thrombectomy, usually we can see if there is a residual stenosis, and if it is more likely to get recluded. I think this is more like a signs of ICAD-related lesion. So there are so many signs just help us to identify if there is ICAS. But I think there are two most important things. Because it's good for us to judge if this patient is highly suspected ICAD-related large vessel occlusion, because for those cases, we will select different catheters, different strategy. So before the procedure, I think the two most important things I just highlighted right here is the occlusion location, and then it's the shape and the short and tapered end of the residual artery. I can show you in the next slides. So the first is about the location of the different etiology. So at the anterior circulation, we know that the embolism usually sitting at the bifurcation site. So if it is ICA bifurcation, M1 bifurcation, and M2 bifurcation, usually it is embolic stroke. But for the ICAD-related lesion, usually it will sitting at the M1 trunk, the siphon segment, and also the ICL initial segment of ICA. So if we saw the different location in the anterior circulation, so we can judge from the location. It will help us to identify ICAD-related occlusion. And for the posterior circulation, usually the embolism just sitting at the basal tip. But for the original part of the vertebral artery and also the V4 segment and the middle and the lower segment of the basilar trunk, usually there will be the stenosis. This is a quite common location for the ICAS. And another thing is about the short and tapered end for the lesion. So from the original CTA, for this case, with the left ICA occlusion, you can see from the original CTA here, this occluded side is at the M1 trunk, and the residual M1 is looked short and also tapered. So from the DSA, you can see here, this is a tapered short end of the M1. And so this M1 is significantly shrunk due to the ICAD. So for this lesion, I think this will be highly suspect this is ICAD-related lesion. But however, we always have to be very careful about this location as a single marker of the just ICAS disease before the procedure. I think there are two very important situations we have to be aware of. And the first is about the fenestration. So for this case, this is after stent retriever placement. We can see here, there is a stenotic lesion here. And after the first pass, you can see at the M1, at the M1, proximal M1, you can see here, there's a fenestration. We have to always be aware of this such lesion, because for this lesion, we should be very careful about using the balloon angioplasty. So usually for such cases, if we do mechanical thrombectomy, it will help us to further identify the etiology of this lesion. And after the mechanical thrombectomy, we can 100% sure if this is a ICAD-related lesion. And so another situation is about early bifurcation of MCA. So for such a case, you can see here there the proximal M1 is totally occluded. So after we place a stent retriever distally, and after the stent retrieval, you can see here this is a very early bifurcation. So from this very early bifurcation, if there is embolus sitting at the bifurcation site, usually you can see the whole M1 segment is occluded. So usually, according to our own experience, for those cases, if there is M1 bifurcation occluded, usually the M1 is relatively longer, so we can still see a residual end of the M1. But sometimes, but for the ICAD-related lesion, because it's a M1 trunk occlusion, so usually we cannot see the proximal end. And at this time, for this early bifurcation, you can see here the embolic stroke. It can make us difficult to judge that. And another thing is about the posterior circulation. You can also see this from this original CTA. This is a basilar trunk occlusion. We can see the proximal basilar artery, and also we can see the distal basilar tip. So usually for this case, it is a basilar trunk occlusion. We will highly suspect that this patient is suffered from ICAD-related occlusion. But after the first thrombectomy, you can still see here, this patient has a basilar trunk fenestration. So this is still embolic stroke. And after the mechanical thrombectomy, we can pull in the thrombus out. And we can see here, this is a VA trunk fenestration. So for this fenestration, we have to be very careful about that. As I mentioned in the previous slides, we should be very careful for using angioplasty for this fenestration, because this vessel is relatively small, and sometimes we may enter the small part of the fenestration, which will make the angioplasty very, very dangerous. So this is how to identify ICAD-related occlusion before the procedure. I think before the procedure is the most important part. And if we just think about it, the patient just using these two criteria and according to the patient's history. And sometimes we will like 80% sure about the patient if it is ICAD related occlusion. So when we go to the procedure, and I think the first question is about, can we do mechanical thrombectomy using stent retriever for an ICAS related lesion? And actually, at the early stage of doing mechanical thrombectomy, a lot of physicians are worrying about using the stent retriever, try to retrieve the clot through ICAD disease. We always think maybe there will be some, difficulties when we try to pulling back the stent retriever, pass through the, passing through the stenotic part. Yes, when we doing that, we did feel some difficulties, but I think there is no evidence for increasing any peri-procedure risk. There's no evidence of increasing the hemorrhage or any other complication for such lesions. So I think at first we think using stent retriever for ICAD lesion is relatively safe. And the other reasons for us try to choose stent retriever for the ICAD related occlusion, there are some 5 reasons. The first reason, and when we try to using stent retriever, we can just restore the antegrade flow very quick, because for the ICAD related occlusion, the clot burden is usually small. And when we just put the stent retriever, the whole perfusion will be completely recovered. And the second reason is about that around 30% of the cases don't require any further PTA. If we just do a mechanical thrombectomy, there will be some mechanical effect on the plaque. And if we using tirofiban after the mechanical thrombectomy, and we just 30% of those cases just okay, you can keep the antegrade flow patent. And the third reason is about it will help us confirming the etiology further. Just as I mentioned in the previous slides, for some difficult cases, although you are very, very sure about this is ICAD related occlusion, but there are still some accident. So if we do a mechanical thrombectomy, usually it will help you just to exclude those very, very rare situation. And the fourth reason, it will get the secondary thrombus out. As we all know, for the ICAD related occlusion, because the occlusion, if the occlusion lasted for relatively a few hours, there will be, because of the blood flow is occluded, so there will be secondary clot, proximal or distal to the occlusion site. So when we do a stent retriever, we can get all those clots, even distal to the ICAS. We can get those clot out, and then we can get a very accurate measurement of the vessel, proximal and distal, which will help us to select a further balloon or the stent device. So for me, I think mechanical thrombectomy using stent retriever should be the first choice. So for this case, I show you here, this is a supraclinoidal ICA occlusion. And for this case, we just using mechanical thrombectomy alone for only once. And from the original CTA, you can see here, this is a supraclinoidal ICA occlusion. And from this location, we will highly suspect this patient is due to ICAD related occlusion. So the rapid shows us there are relatively small core and large penumbra. So during the angle, you can see here, just at the supraclinoidal segment, there is a occlusion, and the distal part from the original CTA, from the distal part can be visualized very clear. So this patient is a very focal occlusion in the supraclinoidal part. So this is a very typical ICAD-related occlusion. So for these patients, we just did a mechanical thrombectomy on using only one pass, using a travel 4x20. After one pass, you can see here this lesion, although there is some residual stenosis at the AP view, but from the lateral view, it looks good. So for this patient, only after one pass using the mechanical thrombectomy, standard retriever, and we still using the tirofiban for this case. And after 20 minutes observation, we can still see the distal blood flow is very good. So we just stop the procedure for this case. And the third reason I think about the procedure, about how to do the endovascular thrombectomy for the ICAD-related occlusion would be about the aspiration. Should we use ADAPT, we mean the direct aspiration as the first line strategy for such lesions? Personally, my answer is no. But however, for my early experiences, actually, we are also worrying about the standard retriever may get some more difficult situations for us. So at our first early experiences, we also try to using aspiration for this ICAD-related lesion. So let us see a case at first. So this is right side patients suffer from right side hand paralysis and aphasia for 30 minutes, and this patient NI stroke score is 16, has a history of hypertension. And from the original CTA, you can see here, this is proximal M1 occlusion. From the DSA angiogram, we can also confirm the proximal M1 occlusion. So from this lesion, and we highly suspect that this patient is an ICAD-related occlusion. So at that time, this is our early cases. So at that time, I'm still worrying about using standard retriever may get some difficulty or some harm to the patient. So I try to using adaptive technique for this case. So I using at that time using intermediate catheter to do the manual aspiration. So after the manual aspiration, you can see here this patient, the distal vessel just get open. It works very well, to be honest, for this case. So using manual aspiration to do the thrombectomy for these cases, it might work. It might work. So for this case, we're using only one manual aspiration, and we can keep the antegrade flow patent. And then for this 3 months follow-up, we can still see this patient has a relatively low cerebral blood flow, and there is still residual very severe stenosis. So for this patient, we did a second stage stent placement using a wingspan stent. So this is after the procedure. However, although we have some experience of using aspiration, it works well for some cases, but I think it does not work for every case because it's really it's difficult to reach the lesion due to the taper end. As I mentioned in the previous slides, for the ICAD-related occlusion, usually the residual artery is shrink and also has a tapered end. So if we do a manual aspiration using a aspiration catheter, it's relatively difficult for the aspiration catheter to reach the proximal end of the lesion. So it's difficult to get the clot out. And the second reason is for the ICAD-related occlusion, sometimes there will be some secondary clot. Maybe the secondary clot located in the proximal end, and also it may located in the distal end. So if we use aspiration, we can get this proximal clot very easy out, but for the distal clot, it's relatively difficult to using aspiration to get this clot out of the stenotic part. So for us, we think we prefer to using mechanical thrombectomy using standard retriever as the first line strategy, but we would not using aspiration as the first line strategy. And another thinking is about for those cases I just mentioned, ICAD-related occlusion has two types. One type is have relatively small clot burden, and the other type has a relatively large clot burden. For this small clot burden, we can use the aspiration catheter to get the clot out, but it is also very easy for us to using this microcatheter first pass effect to identify this. So just for these cases, if we using a microcatheter, usually we using a microwire and a microcatheter to pass through the lesion. When we using the microcatheter and the microwire to pass the lesion, and then we just pull back the microcatheter, and then do an angiogram, you can see there the stenotic part just get antegrade flow. This we will call it a microcatheter first pass effect positive. For such cases, we will this microcatheter FPE will help us to identify if this patient is ICAD related occlusion. It will help us very easily to identify the etiology, and it will also help us to do the further procedure. So this is how I do the ICAS related occlusion. So if this patient, according to the original CTA, we highly suspect this patient is having an ICAD related large vessel occlusion, we will always doing this microcatheter first pass effect, just as I mentioned in the previous slide. So if after we doing this microcatheter first pass effect, if it is positive, we will go directly to the angioplasty and then do stenting. We will not do the mechanical thrombectomy anymore. For if this case is negative or positive plus negative, we will do a standard retriever mechanical thrombectomy, and then we will do the PTA and then stenting. So we will routinely use the RV tirofiban because for this ICAD-related occlusion, as I mentioned before, it is relatively more likely to get re-occluded. So we will routinely use tirofiban. And after each procedure, after each step, we will wait for like 15 minutes to check if we should do the next step. So let us see some interesting cases. So this is the first case. You can see here, this is a MCA occlusion, M1 occlusion. And from this original CTA, you can see here, there is a short tapered end of the proximal M1. You can also see the distal part of the M1. So this case is M1 trunk occlusion, and the distal vessel of the MC is totally visualized. So for such cases, this is very sure to be ICAD-related occlusion. And during the procedure, we can further see there is a short tapered end of the proximal M1, and also very good collaterals for these cases. And for such cases, we highly suspect that this is a large vessel occlusion. We always try to do a microcatheter first pass effect test. So for this case, we're using, you can see here, we're using a J-shaped wire to pass the lesion. It's relatively difficult, but it's still okay to using the J-shaped wire to pass this lesion. And it will make the distal selection very, very safe. And then using the distal wire to the distal part of the M1 MC branch. And then we just using the microcatheter pass through the lesion, and then pull the microcatheter back to the proximal part, and which means we're using this microcatheter to do a very small angioplasty for this lesion. So after we pulling back this, we do angiogram again. You can see here, after the angiogram, you can see there is a stenotic lesion at the M1 trunk, and distal vessels are totally open and totally visualized. So we can confirm ourselves this is ICAD-related occlusion. So for such cases, it's not necessary for us to do a mechanical thrombectomy again, because this is very sure ICAD-related occlusion, and also the clot burden is very small. There is no need for us to do a mechanical thrombectomy. So for this case, we just go directly to the balloon angioplasty. We're using a gateway balloon and to do the dilation. And after the dilation, and we also using tirofiban for such cases always. And we wait for like 15 minutes for each step. For these patients, we're using dilation only, and then we're waiting for 15 minutes. The distal vessel looks good. So we just stop the procedure. And for this case, actually, we just waited for 30 minutes using the tirofiban. So this is a first case. And another case, another left MCA case. And for this case, you can also see here, this is a proximal tapered shrink, the proximal M1. So we highly suspect this patient is ICAD-related occlusion. So for such cases, we just using tirofiban as early as possible. And then when we doing the procedure, we always do the microcatheter first pass effect test. So for this procedure, we do similar stuff. We're using the J-shaped wire to distal branches, and then pull back using the microcatheter, passing through the lesion, and then pull it back, doing a relatively small angioplasty, and then we do an angiogram. You can see here there is no distal clot, so the lesion is totally visualized. So for this case, we also did the direct angioplasty for such cases, and we're using the gateway balloon to do the angioplasty. And after 15 minutes observation, the distal vessel is very good. So for this patient, we only did this angioplasty alone. It works very well. We get ETK3 for this case. And the third case is about the microcatheter first pass effect is positive plus negative case. And from the original CTA, you can see here for this patient, you can see the distal basilar artery is okay, but the proximal vertebral artery is not visualized. So from the rapid, we can see a less penumbra in the posterior circulation. From this angiogram, you can see the right vertebral artery is occluded, and the right ostium of the vertebral artery, there is a mild stenosis. And when we check the contralateral vertebral artery, you can see this vertebral artery is relatively dominant vertebral artery. So we highly suspect that this time this patient is due to this left side occlusion. So we also did this microcatheter first pass effect. We call this is negative. We call this is positive plus negative, because after the microcatheter first pass effect, you can see here, we can see the stenotic part, but you can also see there are a lot of distal thrombus here. So for such cases, actually, from our own experience in the anterior circulation, for the M1 occlusion, usually there are not so many clot, but for the posterior circulation, especially for the vertebral artery, usually you can see relatively more clot. So for this case, although we see this stenosis, but there are some clot distal to the lesion. So we just do the mechanical thrombectomy using the stent retriever. We using the 6x30 stent to cover the clot, and then do a pass to get the distal clot out. So actually, a lot of physicians will challenge that. Can we using the stent retriever to get the distal clot out through the stenosis? The answer is yes. The answer is yes. We have tried this for a lot of times. And so for this case, after first pass, you can still see there are some clot in the distal part of the lesion. So we just did a second pass. We just put the stent retriever here to get all the distal clot out. We get some spasm here. This is a stenosis. And then for this case, we did the angioplasty and implanted Enterprise 4.5 by 28 stent. And so this is a final view for this case. And you can see the vertebral artery, the stenosis is reconstructed very well. And this is a final view for this case. And from the AP view, you can still see a little bit residual stenosis. And this is a fourth case of this, for the first case. And this is also the posterior circulation case. You can also, from the original CTA here, you can also see there is V4 segment vertebral artery stenosis. As I mentioned in the previous case, usually for the vertebral artery occlusion, ICAD-related occlusion, there will be relatively more distal clot. So for this case, after the microcatheter first pass effect, we can see the stenosis, but you can still see the distal part, the better tip actually is occluded due to the distal clot movement maybe. So for this case, we just do a mechanical thrombectomy at the first pass. But interestingly, we just put the sternal retriever. We're using the Theranovas amble trap sternal retriever. We put the sternal retriever into the distal PCA. You can see here, we put this is the distal end of the amble trap. We put the amble trap in the distal part, covering the better tip. After the first pass, we can clear all the distal clot out, and then we can get this stenotic part relatively clear, and then we can get a good measurement about the vessel. So we did the gate V 3.5 balloon angioplasty, and then implant a stent enterprise stent. As although this is off-label, actually this is our first choice for doing the stent placement for the ICAD lesion currently in our hospital. So, and we also did a post dilation for this patients. So this is a final view for this case. It is there is a very small residual stenosis. So this is the last case for this patient for this slice. And for this case, you can see the basilar artery, the posterior circulation is totally gone. So for these patients, when we did the angiography, you can see here the dominant vertebral artery, but after the pica, it's totally occluded. And for this case, we just did microcatheter first pass effect. You can see here, this is totally distal part is totally occluded. So this is a negative case. For this negative case, we will do sternal retriever mechanical thrombectomy as the first choice always. So we did using a solitaire 6x30 to do the first pass. After first pass, you can identify the stenotic part of this lesion, and you can also see the distal part, the better tip is still occluded. So for this case, because this distal part, proximal part stenosis is very, very severe, it's difficult for us to get the devices pass through. So we did the angioplasty first for this lesion, and then to do the second mechanical thrombectomy, but it still fails to get the clot out in the distal part. And then we did a microcatheter aspiration. We're using a Wesco 28 microcatheter. So you can see from this image, the microcatheter is in the better tip, using the microcatheter to pass through all this stenotic basilar trunk. So put at the better tip, and using the Wesco 28 to aspirate all the clot out. So this is very useful for some distal clot occlusion. For this case, because all the basilar trunk have a lot of stenosis, using sternal retriever does not work well. So using the distal aspiration, it also works well. So this is a last angiogram for this patient. We got a ETK3 flow. So to summarize my presentation, I think there are some three take-home messages. The first is about how to identify the ICAD-related occlusion. I think the occlusion location at the tapered end are very helpful to us to identify ICAD-related occlusion. Especially, this is very helpful to us to identify the etiology before the procedure. Before the procedure is always very, very important, because this will help us to prepare our setup. And the second is about the choice about the devices. The sternal retriever is more preferred over aspiration catheter for the first line strategy, because the clot burden, because the stenosis, the aspiration catheter cannot work well for the distal clot. And the third is about how to identify, how to confirm the ICAD-related occlusion during the procedure. The microcatheter first pass effect is always very helpful. It can also help us to distinguish two types of the ICAD-related occlusion. it is a small clot burden or large clot burden. If it is small clot burden, go directly to the angioplasty and stenting. If it is a large clot burden, do mechanical thrombectomy using stent retriever at for one pass. Usually it works very well. So thank you very much. And I would like to take this opportunity to Merry Christmas and Happy New Year to everybody. Thank you very much.
Well, thank you very much. It was indeed very informative. Currently, we do not have any questions, but I would like to ask you, Professor Peng Fei, what about the post-operative management in this patient? What is the BP that you keep, and whether it is dual or single antiplatelets in your center?
Thank you, Raja. I think this is a very, very important question. So as I mentioned in the slides, for the patients with very highly selected ICAD related occlusion, we always using tirofiban during the procedure. So because it works very quickly during the procedure. After the procedure, we will keep using the tirofiban and then give the patients loading dose of dual antiplatelets. Usually we using Plavix plus aspirin, the loading dose. And then after 6 hours, we will try to decrease the dose of tirofiban, and we will keep the tirofiban for like 24 hours to 36 hours and then stop.
And what is the long-term outcome in such patients? Have you observed a tandem occlusion in other places or a recurrence in the same place?
Yes, actually, we did. I did not put a lot of literatures here in my slide. I think this is more like a technical part. Actually, we have did a meta-analysis and also summarized the data in our own hospital. And the re-occlusion rate is really a problem. The re-occlusion rate for such cases is almost 10%. It's almost 10% in the first few days. Usually we did the follow-up CTA at the 3 to 7 days. So between 3 to 7 days. So at this time, we can find almost 10% of occlusion. This is the first thing. And the second thing is about the long-term prognosis. Actually, for the long-term prognosis, a lot of patients recovered very well. I think also from the literature, we did a comparison between the embolic stroke versus ICAD stroke. It seems there is no difference, but personally, I think there should be difference. The reason are maybe two reasons. The first reason is usually the ICAD-related large vessel occlusion patients are present to the hospital relatively late. And the second reason is currently we did the ICAD-related occlusion. Usually it's relatively complicated, the procedure. So it takes a relatively long time to finish the procedure. So these two reasons may cause relatively lower good outcome for such cases. But I believe if we do the right cases, if we get the patients early, we will make such patients should be better outcome.
Thank you very much. If there are any comments from our honorable speakers or chair, Professor Keller, would you like to say something?
Well, I'm just fascinated what you're doing. It's not my specialty at all. We just have some problems, of course, with those patients afterwards if they have some neurosurgical issues with the oral anticoagulation and the thrombocyte aggregation medicines to stop it. So what is important for us to know, if they have another neurosurgical problem, we have to do some surgeries. How long we have to wait? How long you need your anticoagulation after surgery or after your procedure?
Thank you, Professor Keller. I think this is relatively, I just selected this topic here because this is a kind of Asian population unique disease. And for your question, I think this is very important. according to the guideline, actually, for the ICAD-related disease, usually we will recommend the patient to take dual antiplatelet for at least 90 days, to prevent the secondary stroke. But especially for those patients receiving the stent, relatively, we will be more careful about that. But for some cases, usually we will do the anastomosis under single antiplatelet. So for the after stent placement, usually we will, after 3 months, we will let the patient just take single antiplatelet. I think after 3 months, it's okay.
Okay, thank you. Professor Klaus-Resch, any comments from you?
Well, regarding anticoagulation problem, this became a very difficult subject, very complex subject because of the many drugs we have nowadays. Therefore, in our department, we have a specialist always available who will advise us in each single case the management of anticoagulation and advise us when we can go in a new procedure if necessary. It became a very complex issue that cannot be decided anymore by the neurosurgeon himself.
Well said.
Thank you very much for your comment. Totally agree with that.
Ben, would you like to ask something?
Yes. Thank you, Professor, for your lectures. So my question is about the use of a balloon-guided catheter. So in some European countries, they advocate the use of the balloon-guided catheter. So may I ask, Professor, do you have any experience with that?
Yes, thank you. Thank you, Ben, for your question. Excellent question. I think a balloon-guided catheter is very useful for doing mechanical thrombectomy, especially for those etiology due to the embolic stroke. But for the ICAD-related lesion, as I mentioned in my slides, most of the cases, they have relatively small clot burden. So personally, I think it is not that necessary to using a balloon-guided catheter for such etiology. That's my answer. Thank you.
And may I ask, I saw that in your center you use those rapid software, right? And may I ask, do you encounter any problem in arranging the logistic for the rapid software for interpretation? Because like in some centers, the logistic problem may make that from the CTA to the rapid interpretation, it may take some time. Some will advocate. So in your center, do you encounter this problem, and how would you solve it?
Yeah, in our hospital, I think rapid works relatively very well, but we just met some cases it's not that accurate. Sometimes we have to read it using the physician their own opinion. So I think it's still very fast and very good. We did not encounter any logistic problems. Thank you.
Thank you so much.
Thank you, Ben, and thank you to our honorable speaker, Peng Fei, for this wonderful session. And I think it's time to close, and I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito. I would like to thank both the speakers of today, Professor Uwe Keller and Professor Peng Fei, as well as Chair Professor Klaus-Resch, for this time and support for the ACNS webinars. Really grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 400 people who have joined us live. A special thanks to my co-host Dr. Liu Pun Seng and our YNS member Ben for joining me today. So until we all meet tomorrow online, it is bye-bye from all of us. Thank you very much for joining.